Hey everyone, welcome back to Dr. MS Corpus. If you have watched part 1, you already know how pain starts at the nociceptors and travels through the nerve fibers. But here's what we didn't answer. Where does that signal go? How does stubbing your toe send a message to your brain in less than 50 milliseconds? And here's the really important question for clinical practice. Why does some pain never go away even after the injury heals? I want you to think about this. Have you ever known someone with chronic pain? Maybe fibromyalgia, back pain that just won't quit. Their MRI looks normal, but they are in agony. Why? Today we are uncovering those answers in our part 2 of the pain physiology. By the end of this video, you will understand the exact pathways that carry pain from your spinal cord to your brain, why crossing matters clinically and how it helps diagnose spinal injuries, sensitization, why your nervous system gets stuck on high alert sometimes, and the wind up, where pain literally creates more pain. Let's go. Okay, so nociceptors have detected danger and they have fired off their signal. Now what? Think of your spinal cord. Spinal cord has a major processing station, specifically the dorsal horn. That's where the pain signals first arrive, but they don't stop there. They need to get to your brain so you can actually feel the pain and respond to it. And here's the cool part. There are multiple pathways like different highways, each carrying different aspect of your pain experience. Let me break down the 4 major routes. The first, the spinothalamic tract. It carries the sharp, localized pain and temperature sensation. Here's what's crucial about the spinothalamic tract. This pathway crosses to the opposite side of your spinal cord about 1 to 2 segments up from where it enters. Remember that it crosses. We'll come back to this. The second one, the spinoreticular tract. This carries the emotional and suffering component of pain. It connects to your limbic system, that's your emotion center. This is why pain doesn't just hurt physically, but it makes you feel miserable. It's not just in your body, it's in your mood, your emotions and your whole experience. The third is the Spinomesencephalic tract. This is your body's fight back response. It activates an area called the periaqueductal gray matter, which is basically your brain's internal morphine factory. We'll talk more about this in the next part. And finally, the trigeminal pathway. This handles all facial and cranial pain, everything from your neck up. It's basically the spinothalamic equivalent for your face. Now here's a question for you. Why do you think the brain needs multiple pathways for pain instead of just one pathway? Think about it and comment below. Alright, yes. Remember how I said the spinothalamic tract crosses to the opposite side and it's clinically important? Let's talk about it. Imagine you're in the emergency. A patient comes in after a spinal cord injury. They have lost pain and temperature sensation on the left side of their body below the injury, but their motor function and proprioception are gone on the right side. What's happening here? This is called the Brown-Sequard syndrome, where one half of the spinal cord is damaged, that is the hemisection of the cord. Because the spinothalamic tract crosses, pain and temperature is lost on the opposite side, but motor pathways and proprioception, which travel through different tracts, are lost on the same side. This is an anatomical detective work. You can diagnose the exact location of a spinal injury within minutes before you even see the MRI, just by understanding this crossing pattern. Pretty powerful, right? A question for you. If a patient loses pain sensation on their right leg after a spinal injury, which side of the spinal cord was damaged? Left or right? Comment below. Then, we are getting into something really important and honestly kind of heartbreaking. Sometimes patients experience excruciating pain even though there's no injury, no inflammation, no tissue damage whatsoever. How is that possible? Because the pathway itself has been malfunctioned. The pain isn't coming from the damaged tissue, it's coming from the damaged nervous system. Let me give you an example for this. The thalamic pain syndrome. Imagine a patient has a stroke that damages their thalamus. That is the brain's central relay station where all the sensory information gets processed. What happens? The neurons start firing chaotically. It's like radiostatic, but the brain tries to interpret this noise, and what does that perceive? An intense burning pain. These patients describe their skin feeling like it's on fire. That is, they are in agony. And the worst part, traditional painkillers never work. Why? Because there's nothing to treat. There's no inflammation to reduce, no injury to heal. The relay station itself has become the source of their pain. Let me give you some other examples of neuropathic pain. The diabetic neuropathy. It is high blood sugars damages small nerve fibers. They start misfiring constantly. Patients get burning feet, worse in the night, with pins and needles that never stop. The phantom limb. A person loses their legs, but years later also they continue to still feel pain in the toes, which doesn't exist anymore. This is because the brain's body map has not been updated. Post-herpetic neuralgias. Herpes rash healed months ago, but still the pain persists because this herpes would have damaged some of the nerves. Fibromyalgia, widespread pain, no structural cause. The nervous system has just become hypersensitive to everything. Here's the pattern. In every case, the problem isn't in the tissue. It's in the nervous system itself. And that means clinical correlation. The treatment must target the central nervous system, not the peripheral. Now, think about this. You have a patient and you need to explain him that all the tests are normal, but yet their pain is real. How do you explain this condition to a patient? Drop your thoughts and suggestions in the comments. Let's talk about sensitization. Imagine a brand new smoke detector has come and it's perfectly calibrated, goes off when there is real danger, like an actual smoke, actual fire. This is mad. But now imagine it becomes hypersensitive, the opposite. Steam from your shower, there's an alarm. Burnt toast, there's an alarm. Someone walking by with a perfume, again an alarm. That's what happens with sensitization in our body also. Your pain system detection becomes oversensitive and starts firing in response to things that shouldn't hurt at all. There are two types and you need to know both of them. The type 1 is peripheral sensitization, which happens right at the site of injury. That is, nociceptors themselves become hypersensitive. They lower their thresholds and fire more easily. That is the mechanism. And this is termed to be primary hyperalgesia. Remember the example of sunburn I mentioned in part 1? Even gentle touch stings at the burn site. That's peripheral sensitization. This is usually temporary, and as the inflammation resolves, it goes away. The other one, central sensitization. This is where the things get serious. This happens in your spinal cord and brain at the signal processing level. It's like someone cranked up the volume of an amplifier. Now, every signal, even a normal, non-painful signal also gets amplified into pain. Here's how you can think about it. Peripheral sensitization is like microphones at the injury site. Become too sensitive. Whereas central sensitization, the amplifier in your spinal cord and brain gets too cranked up high. Let me give you a clinical picture. A patient, 34-year-old female with severe back pain for chronic back pain for 2 years have come. Physical exam, normal. MRI, no disc herniation, no structural problems, and everything looks fine. And the doctor Treating doctor says everything's fine, there's nothing wrong. But the pain of patient, real, debilitating and life altering. What's happening here? This is central sensitization. The original injury might be a minor strain which has been years ago healed completely, but the nervous system never got the memo of it. It's still on high alert, amplifying every minor signal into pain. The injury site isn't the problem anymore, the alarm system is. This is why treating only structural problems often fails in chronic pain. You need to target the sensitized nervous system itself. Now a question for you. What class of medications do you think would help central sensitization? NSAIDs or something that acts on the nervous system itself? Comment below. Now we arrive at one of the most fascinating and devastating properties of pain processing, the wind-up. Let me tell you about an experiment from the 1960s that changed everything. Researchers applied identical electrical pulses to a nerve fiber over and over, all at the exact same intensity. First pulse, 2 by 10, mild pain. 10th pulse, 4 on 10. 15th, 7 on 10. By the 100th pulse, it became intense and subjects were pulling away reporting intense pain. But here's the crazy part. Nothing about the stimulus has changed. Same intensity every single time. But the nervous system was amplifying its own response. It was turning the volume up automatically with each repetition. This is called the wind-up. Pain creating more pain. Let me explain what's happening at the molecular level in your spinal cord. The repetitive C fiber firing floods the synapse with two chemicals, the glutamate as well as substance P. Normally, the NMDA receptors remain blocked by magnesium. But this glutamate and substance P activate the NMDA receptors, that is, they remove the block. Then calcium rushes into the cells, that is the dorsal horse neuron cells. These neurons become hyperexcitable, leading to identical pain each single time, generating a progressively larger response. Let me give you a relatable example. Imagine someone tapping on your forearm with their finger at the same spot, same force, but every 3 seconds. For the first 10 taps, it's slightly annoying, right? 11 to 30, you start feeling uncomfortable. 31 to 50, you're flinching now, warning them to stop. 51 and beyond, it's genuinely painful and you pull your arm away. Nothing about the tapping changed, your nervous system has changed here. This isn't just a lab curiosity. Wind-up drives some of the medicine's most challenging pain conditions, like the diabetic neuropathy that gets worse year after year even with good glucose control. Fibromyalgias, where constant low-level input creates wind-up over time, making even light touch painful. Post-surgical pains, that's far beyond what the surgery should cause, because of repetitive input trigger causing wind-up again. And the cruel paradox is opioid-induced hyperalgesia. Chronic opioid use can actually worsen their pain through similar NMDA-dependent pathways. Opioids are meant for pain control. They cause pain control. But here, they on a chronic usage can worsen pain through the same NMDA pathways again. It's a trap. Patients require higher doses, but you cannot give. The patient gets worsened with the higher doses. But here's the good news. Understanding this wind-up through all these experiments have revolutionized the chronic pain treatment. If NMDA receptors drive wind-up, then blocking them must prevent it, right? And it does too. This is why we use ketamine at low dose, which directly blocks NMDA receptors. And this stops wind-up at its source, used for severe refractory pains. Then the gabapentinoids, like the gabapentin and pregabalin, these block calcium channels, reduce the glutamate release, and these are first line for neuropathic pains. SNRIs like duloxetine, they enhance your body's own pain inhibition. That is, They boost serotonin and norepinephrine, enhance your brain's own descending pathway control, and these are great for fibromyalgia and diabetic neuropathy. Tricyclic antidepressants like amitriptyline, they act through multiple mechanisms. They enhance descending inhibition and block sodium channels. These are especially good when pain disrupts the sleep. This is why ibuprofen doesn't work for fibromyalgia. Physical therapy alone fails in chronic pains. Some patients need antidepressants for pain even though they are not depressed. Why? Because here we are not treating the tissue. We are treating the nervous system's learned response to pain. See how understanding the mechanism changes treatment. We are just not treating the symptoms. We are targeting the root cause that caused the pain. Then the main takeaways from our session today. Pain travels through multiple specialized pathways. Spinothalamic for sensation, reticular for emotion, spinomesencephalic for pain control. Then the spinothalamic tract crosses to the opposite side, helping diagnose spinal injuries instantly. Sensitization. Sensitization makes your nervous system hypersensitive, and that causes overreaction of your this, and peripheral happens at the site of injury, central happens in the spinal cord itself. Wind up is pain amplifying itself through NMDA receptor activation. This is why chronic pain can get progressively worse. Treatment strategies. Treatment must target the central mechanisms and not just peripheral inflammation. Got all that? Excellent. Let's talk about how we fight back against these mechanisms. The paradigm shift in pain medicine is that the chronic pain isn't just about inflammation. It's about maladaptive neuroplasticity. That is, your nervous system learning to amplify pain. Hence, the treatment strategies, what we have all spoken, are targeting the central mechanisms and not just the peripheral injuries. So, we are not treating the tissue damage. We are treating the nervous system's response to the tissue damage. Then, so a question, now let's say a patient with fibromyalgia asks, why doesn't ibuprofen help my pain? You explain that their pain is caused by central sensitization and it is not inflammation. So you tell them we are not treating the tissue at the site of injury, we are treating the brain's response to that pain. But then they ask, if my nervous system is just overreacting, does that mean the pain is in my head? Is the pain not real? How would you respond to it? Think it through. And yes, your explanation might help. Share your answers in the comment section so that your explanation might help another student learn to communicate better with their patients. Yes, you have just learned why some pain never goes away even when the injury heals. You understand sensitization and wind up, the two mechanisms that transform acute pain into chronic suffering. But we are not done yet. The part 3, the final part of the series of the pain, we are going to cover the different types of pain, why they feel so different. Referred pains, why heart attacks cause arm pain, why gallstones hurt your shoulder. The gate control theory, how rubbing an injury actually reduces pain. Your brain's built-in morphine system, the descending pain modulation. Complete treatment strategies that tie everything together. And don't forget to hit that like button if this helped you understand chronic pain better. Subscribe for part 3 coming next week. Check out the practice quiz in the description and share with these classmates who are struggling with pain physiology. Follow me on Instagram for daily clinical pearls and email me at Dr. MS Corpus with any questions. Thank you so much for learning with me today. I'll see you in part 3 where we complete this pain journey together. Take care.